Thanks very much, Christian, and the rest of the scientific committee for having me out. The idea of, or the experience of having French Chardonnay, 30,000 feet in the air, is completely new to me, but very enjoyable. What I'd like to do is focus in on anatomy and biomechanics. So I apologise for the outset that this is what I'm dealing with. It's probably what I spend most of my research activity focusing on. And then I also work clinically as a physiotherapist at one of the Australian football teams. So, 3/4 of my time is clinical, and then 1/4 of my time is focused in on research activities. So if we start with, I guess, looking at the challenge of clinical examination in groin pain, I think we'd all agree that it can really be particularly challenging. And there are a few reasons. Firstly, we're dealing with a variety of anatomical structures. So the adductors, the flexors, the abdominal muscles, the pubic bone, inguinal tissues. We can be dealing with a number of different tissues themselves. So muscle, tendon, bone, ligament, nerve. We have a variety of clinical presentations. Short versus long duration of symptoms. Acute versus subacute presentation of symptoms. And I guess lastly, we're dealing often with mixed pathology, inflammatory versus degenerative changes. And I'm hoping that by looking at some of the anatomy and biomechanics, we can achieve a bit of clarity with regards to our clinical examination. So I'm going to focus in on the anatomy and then some of the biomechanics. This is not exhaustive. What I've tried to do is pick out some key principles. And look, hopefully tomorrow in the radiology session, we'll advance on some of the information that I present here in a bit more detail. So as we all know, one of the common structures that gets involved in groin pain is the proximal adductor muscles, and more specifically, probably the tendon tissue. So let's look at the anatomy and morphology of these structures. Well, we know that adductor brevis and adductor longus have both superficial tendon along the anterior surface of the muscle, and then also an intramuscular tendon. The adductor longus has the longest proximal tendon, and you can see it there on the left-hand side. So the border along the medial margin is longer than the lateral margin. So loosely speaking, 6 to 7 centimetres on the medial side, and then about a couple of centimetres on the lateral side. And the adductor brevis and gracilis tendons, you can see on the left here, are typically fused together, just inserting close to where the arcuate ligament exists at the base of the pubic bone. The other thing I want you to notice on this left-hand picture is the appearance of the adductor longus tendon. Now, this is one of the cadavers that we dissected, and it was a bit of an anomaly because you can see here that the tendon's actually extending from the medial to the lateral margin at the enthesis, and that wasn't an observation that we saw in the majority of the cadavers. So I guess the question then becomes, well, what do we know about the cross-sectional area of the adductor longus tendon and the other adductors close to where they attach? And there are a couple of studies that we can look at here. So firstly, Strauss et al. Published some work in 2007 in American Journal of Sports Medicine. And these are the relative data for the tendon at 0, 1 and 2 centimetres from the attachment. And what you see is that the tendon along the anterior surface of adductor longus makes up less than the muscle as far as the total cross-sectional area is concerned. And as we get further away from the attachment, that cross-sectional area gets less. More recently, we've had some data from Davis et al. In British Journal of Sports Medicine, again looking at not only adductor longus, but this time adductor brevis and gracilis. And you can see the blue bars constitute site A, which is close to the enthesis. The orange is B, which is at the partway through the tendon, and then the grey C is at the muscle tendon junction. And look, a similar picture in terms of reducing cross-sectional area of tendon as we get further away from the attachment. But you'll see there's a little bit of disparity between these two studies regarding the composition of the adductor longus at the attachment. So Davis et al. Are reporting sort of almost tendon in complete cross-sectional area, just a little bit of muscle on the deeper surface, whereas Strauss found that the bulk of the cross-sectional area of the attachment was actually muscle on the deeper surface. And Look, I think this is probably anatomical variability, maybe some differences in histology, in the way they've obtained the data. Because certainly when we did our dissections, there was quite a degree of variability in how much muscle was sitting on the underneath surface of the tendon. So if we start looking at what happens as we go further up to the symphysis, and we go to modern textbooks and look at, well, what do they describe regarding the proximal adductor attachments? And we get a fairly simplistic picture. And yeah, look, they're technically correct in that the tendon does attach to the pubic bone, just near the body of the pubis, inferior to the pubic tubercle. But the problem with these simplistic descriptions is it implies that we have discrete anatomy. And that's just clearly not the case. Now, if we go back in time a little bit and look at some of the original anatomical texts, we get a very different picture. And I'd like to focus in a little bit on this first text by Professors Tetsu and André Ladege. Now, Professor Léo Tetsu in Lyon in France put this book together in, I think originally in 1902. And you can see quite clearly on the left-hand side, the connections between Adductor Longus and brevis forming this tendinous network across the anterior symphysis. And then below, we've got the rectus coming in and attaching to the pubic symphysis capsule. So in actual fact, we've known for quite a while that there is a fair degree of anatomical complexity across the front of the symphysis. Around a similar time to the French anatomist, we had Professor Eisler publishing his text, I think in 1902, if memory serves me correct. And whilst there wasn't a lot of detail in the text, there certainly was this great picture in his book, which gives us a very, very, I guess, detailed visualisation of the attachments, rectus, adductors, and also the ilioinguinal ligament coming in laterally. More recently, we've had some scientific investigations come through to confirm a lot of the anatomical complexity that it does exist at the front of the symphysis. And this particular work was conducted by Gibbon and Childers, and I believe it was done in the late 90s. And what they did a number of dissections on embalmed cadavers and reported quite extensive interdigitations between the rectus, the ilioinguinal ligament, the adductors from below. And I think more specifically, what is interesting here is this extension in the ilioinguinal ligament as it comes across the front of the symphysis, almost forming like a V shape. And you've got the rectus and pyramidalis coming from above, and then the adductors coming in from below. So you end up with this strong sort of functional structural unit at the front of the symphysis. Now this, I guess, rectus-adductor connection doesn't just slide across the bones. Phil Robinson's shown us very well in cadaveric dissections that these muscles are firmly adhered to the underlying capsule of the symphysis. And this happened in all instances of the 17 cadavers that he examined. Now, sometimes it was tendon of the adductor that was attached to the capsule, sometimes it was muscle, but yes, we had firm adhesions between the common sort of rectus adductor connections and the capsule. In our dissections, we observed exactly the same thing. So here's a couple of pictures of two different cadavers. The left is the one I was referring to before, which was, I guess, the anomaly where we've got this quite thick adductor longus tendon, but you can see how intimate it is with the anterior rectus sheath. And then on the left-hand panel, we have, I guess, an instance where we saw some unilateral connections going on. So here we've got the right anterior rectus sheath communicating with the left adductor more so than the other side. But this appearance, I guess, made us think, well, can we test out whether or not there's some sort of mechanical integrity to this connection? So what we did is we got some cadavers, we stabilised them to a bench, put a winch with as you can see here, some calipers attached to the adductor tendon, and then on the bottom picture you'll see some strain gauges attached to the rectus sheath on the contralateral side of the symphysis. So what we hoped to see was that we could pick up some sort of increase in tissue tension in the rectus sheath when we loaded the proximal adductor tendon. And the data on the left-hand side there is an example cadaver where we did observe exactly that. So you can see the top graph is illustrating the force coming out of our winch where we loaded it up by 30 newtons, and then the bottom graph is depicting the strain gauge data. Look, I will point out that this particular observation is not something we observed across all 10 cadavers. We were using embalmed tissue, which is got a lot of problems with these sorts of experiments, but I guess you can see it as more of a proof of concept type study. What about the inguinal area? Well, I think much of our anatomical knowledge in the inguinal area is owed to an American surgeon who performed some dissections in the late 1950s. I think the motivation was around pre-peritoneal hernia repairs, and when he was getting taught how to do these repairs, I think he had very little physical concept of the anatomy that he was dealing with. So off he went to the dissection room, and I think he ended up dissecting 135 fresh cadavers, and very, very carefully detailed some of the anatomical relationships that exist in the inguinal area. And I'd encourage you to go and chase up Robert Condon's work if you want to look at this in any detail. But there's a couple of points that I want to raise to you today that I think are really worth bringing up. The first is the lateral attachment of the common sort of transversus internal oblique muscles. And it's often referred to as being along the lateral part of the inguinal ligament, but in fact it's more on a thickened band of fascia that's coming off the psoas, which is called the iliopectineal arch. And I guess the important thing there is that it's probably creating this intimate anatomical relationship between the psoas and the lateral abdominal muscles. Then if we go across medially, which you can see in the left-hand cadaver dissection here, you can see the superficial inguinal ring. But if we look underneath that and get the sort of conjoined aponeurosis from internal oblique and transverse abdominis, what Condon noted was that aponeurosis is coming into the lateral rectus sheath and attaching sort of more than half a centimetre above the pubic tubercle. And again, if you go back to most of your standard anatomical textbooks, you'll typically see this description of a conjoint tendon coming down onto the pubic tubercle, which, according to his dissections, just wasn't the case in the majority of situations. But I think what becomes clear when we look at the inguinal anatomy is how much of a clinical challenge we have with our examination. So within a very close proximity to the pubic tubercle, we have the rectus attachment. We have this conjoined aponeurosis from internal oblique and transverse abdominis coming in laterally. Of course, we've got the superficial inguinal ring from external oblique, and then obviously we've got the inguinal ligament. And so it can be very challenging to work out where exactly or which structure is the primary source of the symptoms that the player might be getting in this area. And maybe this is where we need to look to imaging to help us out. So underneath all this soft tissue network, we've obviously got a joint, the pubic symphysis. And as you'll see from some work done in the mid-80s by Walheim et al., that the symphysis normally does not move much at all. Its greatest mobility is in the vertical direction, not surprisingly. But in normal people, we see very, very small degrees of rotation and translation. So the joint is essentially a stiff joint that is built to handle large forces. Now, does the pubic symphysis actually contribute to pelvic ring stability? Or if we just completely cut the symphysis, will the ring stay stable? And it's all dependent upon the sacroiliac joint. And we can see here that, yes, you slice those ligaments and you get a clear change in the force displacement behaviour of the pelvic ring. So the ligaments are important to us as far as symphyseal stability is concerned, or pelvic ring stability for that matter. And perhaps when we see an MR that looks like this on the left-hand side, where you've got this gross thickening of the suprapubic ligament associated with some pretty serious degenerative changes or destructive changes to the arcuate ligament complex and the adductor attachments, that maybe we're starting to get an issue with symphyseal stability. What about the hip joint? Can that impact upon how the symphysis is moving? And I guess the link between hip joint mobility and symphyseal mobility was first proposed to us in 78 from Williams, just a case series in British Journal of Sports Medicine. But more recently it's been looked at in a cadaveric study by Birmingham et al. In 2012. Now, understand this is a cadaver study, and I also understand that the cam lesion was modelled by just attaching a wooden dome to where the cam would otherwise exist. But it does open up the possibility that if we have got a cam lesion, albeit maybe asymptomatically, it can impact upon symphyseal motion, which you'll see there in the figure. So the cam is the red line, and the native, before putting that wooden button on, is the black line. And once we get past sort of 10 to 15 degrees of torque of internal rotation at 90 degrees of flexion, we start to see a difference in the mobility of the symphysis. And this finding, I guess, has a couple of implications for us with our clinical exam. It perhaps starts to give us some understanding of why we sometimes see coexisting hip and adductor-related pathologies. But even just more simply than that, when we've got someone on the plinth and we're examining them, we take their hip up to 90 degrees of flexion and we turn it into internal rotation. Once we take up that, I guess, that bony block in the hip, then chances are we're starting to stress the symphysis a little bit. So it's really important when we're twisting the hip into internal rotation at 90 degrees is where is that pain? Is it coming from somewhere that might be attributable to the hip? Or if it's just reproducing adductor-related pain, perhaps the hip is asymptomatic in that instance. Looking at, I guess, the mechanics of the adductor muscles and what information that can help us with our clinical exam, I think there's two key parameters that we want to look at here. Firstly, physiological cross-sectional area, and secondly, moment arm. They're the two properties that are going to tell us what these muscles do as far as movement is concerned. So the first property, physiological cross-sectional area, you'll see in the little diagram there is the green line. So it's the area perpendicular to the muscle fibres. It's not the anatomical cross-sectional area. What this parameter is telling us is if we fully activate the muscle, how much force do we get from that muscle? Now, on the plots here, I've got the adductors and the hip flexors, but I've also put soleus and sartorius on the plots as well to just give you some two extreme examples. So if we're talking about a force producer, we're talking about a muscle that has very short fibres, but a very wide physiological cross-sectional area, a la soleus. But if we're talking about a muscle that really doesn't produce much force at all, it's just designed to handle large excursions, that's sartorius. Now notice that adductor magnus probably sits a little bit towards a force producer. Gracilis, not surprisingly, is a little bit more towards what we see for sartorius. But for the main adductors and hip flexors, they're all bunched together. There is really no difference here in their design. But what splits these muscles in terms of function is their moment arm. These graphs here show the flexor and extensor moment arms, which is the blue squares, and then the adductor moment arm, which is the yellow circles. And what these are plots with increasing angle of hip flexion, because I've kind of figured that's probably the most interesting change that we're going to see with these moment arms. Now, if we look at the adductors on the right-hand side of your screen there, we can see that their moment arm is around 6 centimetres. And as we increase the angle of flexion, adductor longus and adductor brevis really don't change too much. It's not of any great surprise, but you can see the adductor magnus starts to drop off a little bit as we flex the hip. And perhaps this explains to us why when we get our squeeze test up to 90 degrees of flexion, that we start dropping off in the force that can be produced in that position. The second thing we see is that most of the muscles, except for perhaps adductor magnus, are synergists. They're all got adductor moment arms and flexor moment arms. Yes, that changes a little bit as we increase the angle of hip flexion. So you can see that, say, for adductor magnus, as soon as we go past an extended position, or neutral standing, all of a sudden it has a extensor moment arm, not a flexor moment arm. But for the two adductors, we really have to get up to about 80 degrees of flexion before we start seeing the moment arm swing towards an extensor. The last thing I want to point out to you here is note the difference in the y-axis scales for the flexor moment arms for psoas and iliacus and adductor longus and adductor brevis. So you'll see that adductor longus at around 20 or 30 degrees of hip flexion has a moment arm that's greater than adductor brevis for flexion and is also substantially greater than psoas and iliacus. So if we want to talk about what a primary hip flexor is, I think we need to start pointing the finger at adductor longus more so than perhaps psoas and iliacus. And yeah, sure, the kicking and the change of direction is a key mechanical thing that is going to load the adductor muscles and create pathology, but equally so, sprinting is certainly putting a lot of load on adductor longus as well. So what does all this mean? Well, there's probably two things with our clinical examination that I think some of this information has importance for. And the first is palpation. It's an incredible, valuable tool for us. And we see evidence of the role of palpation in Per Holmig's clinical entities approach. But palpation skill is dependent upon your anatomical knowledge. So you cannot palpate what you don't know. And again, if we have a look at the cadaver section here, think about palpating the common adductor origin on a patient that you see in the clinic. Are you just a little bit too high? And are you hitting the ilioinguinal ligament attachment? And when I say a little bit too high, we're probably only talking about a half a centimetre or so. Or have you clearly felt the medial and lateral margins of that tendon, in which case you're really compressing the tendon against the underlying fibrocartilage? Or are you just a little bit too low, in which case you're right on gracilis, adductor brevis, or even that arcuate ligament? We don't have to be too far away to be changing what we're actually pushing on here. Resisted muscle contractions. So take, for example, hip flexion. We can see the top position, if we take a resisted muscle contraction in the Thomas test position, what structures are we loading here versus when we got the patient in sitting and we're resisting hip flexion in this position. So in the top position, if we remember, adductor longus has a very, very big flexor moment arm when the hip is in a neutral position. So not surprisingly, in the mid-90s, an Australian physio, Anthony Hogan, discovered that this particular position for resisted flexion was quite provocative for adductor-related groin pain. And I think you can see if we've got a strong moment arm where adductor longus can flex the hip in this position and we have strong connections between the adductors and the rectus muscles, this particular test can be a very useful pain provocation test for us in athletes with groin pain. Whereas this bottom position here is probably more specific to iliopsoas. So if our target is measuring the strength of iliopsoas, then perhaps it's the sitting position that we want to look at. What about the squeeze test? We often vary the angle that we're using for our squeeze test measurements. And we need to think about the line of action and the moment arm changes that there happen to the adductors as we change those angles of hip flexion. That could help us in instances where we might have pain being reproduced at 0, but when we put them up to 45 degrees, all of a sudden they're no longer painful and they're much stronger. What does that mean in terms of the likely structure that is going to be sore? So hopefully this information is giving you a little bit of an insight into how it can be important for our clinical examination process, of which we'll go into in more detail in the next presentations. So thank you very much.